Okay, class, today we are going to talk about it's not really a concept, but it encompasses all of the concepts that you have been learning about this semester. And so what we're going to talk about today is perioperative nursing, what goes on prior to surgery, during surgery, and after surgery. Okay. So, the term perioperative refers to, like I said, the preoperative, the intraoperative, and the postoperative phases of the whole surgical experience. And, most surgeries, they're performed in like acute care hospitals, and many, patients, they have their surgery in, an outpatient or what they call like an ambulatory setting. But when we look at it, the perioperative phase, is where the surgical experience begins, where the decision is made to actually do surgery. And then it ends when the person is transferred to the surgical suite. Okay. During the preoperative phase, the nurse plays like a really major role in assessing the physical and psychosocial needs of the patient. And this is, to help create a safe and efficient perioperative experience. So teaching is really critical during this phase to prevent any kind of complications and to really promote a speedy recovery. So the patient consents to have surgery in this preoperative phase. And the surgery generally requires general anesthetic, so that patient renders him or herself dependent on the knowledge, the skill, and the integrity of that healthcare team. And then in accepting this trust, the healthcare team members have, an obligation to make the patient's welfare their first consideration during the surgical experience. Patients, they face, when they're facing surgery, they experience, fear, anxiety, about many of the aspects of surgery. So, they have fear of the anesthesia, fear of the surgical findings, and uncertainty of the surgical outcomes. During this time, the perioperative nurse assesses the patient's perception of the surgery, what knowledge they have about the procedure, including informed consent, the expectations of care, stress level, any cultural or religious beliefs, support from family or significant others, or they also assess any nonverbal behavior. This, for the perioperative nurse, also is a time to build rapport with the patient, to build confidence in the patient's perception of their care, as well as aid, this time helps aid the perioperative nurse to develop, along with all of these things that they're obtaining from the patient, the best plan of care for the individual patient. So perioperative equals admission to discharge. So as the patient moves through the three phases of the operative process, the perioperative nurse must adapt the assessment in each setting. The scope of activities, they include establishing a baseline assessment, which all of you know. When you get the patient, you do a baseline assessment. If anything changes, something has changed from when the patient presented. Carry out any preoperative interviews, prepares the patient for any anesthetic to be given, and the surgery. In addition, they collect data, they identify any needs of the patient, and like I said, they develop a plan of care and any communication needs that the patient may require. Most patients will go through the 3 phases of the perioperative experience. On occasion, a patient may come directly to the operating room and bypass the preoperative phase altogether. Some patients may skip the PACU. They may skip the PACU phase and be transferred directly to the intensive care unit or another setting. So safety is our number 1 priority. So the perioperative team, and that's everyone, does what is necessary to make sure that that patient stays safe. So we're looking at the right patient, the right procedure, the right site. Okay, when we assess a patient, it's going to be individualized. So they're going to have to identify the patient. So we need 2 patient identifiers. Usually the name and the date of birth. And this may be individualized specific to the organization, but identify the patient, name, date of birth, and then operative procedure. What side, location, you're going to mark the site. You're going to also perform teaching and make sure that the patient understands, and then that they verbalize that they understand the procedure. And then during this time, like we say, safety is the biggest thing. Safety first. So you need to see if or make sure that the patient reports any allergies or sensitivities to medicine, food, tape, latex, if they have any immune deficiencies, which, will increase the risk of infections and delay healing. You want to make sure if they have any cancer or any recent cancer therapy. You want to make sure that the patient doesn't have a family history of malignant hyperthermia. And we'll talk about that. Malignant hyperthermia reaction to anesthesia. You want to make sure they don't have any autoimmune disease, because we want to make sure that we assess for a hypermetabolic state. Okay. We want to make sure that they don't have a history of hepatic disease, because this is going to affect drug detoxification and may alter coagulation. So we want to make, it's going to, if they have any issues with their liver, the medicines that go through, they may not be filtered correctly to be eliminated out the body. And then the liver controls coagulation, so we have to worry about bleeding after surgery. And then we have to know if they have any blood transfusion reactions. Okay. Now I do have 2 videos. Check them out. It talks about the whole perioperative nurse and what they ask for, and it kind of restates or reiterates what we're going to be talking about today. And as y'all know, I have videos throughout that I think that are really good. So when we're talking about the team, the perioperative team, the surgical team. So now we're talking about the intraoperative team. Let's talk about that perioperative team, but let's talk about the intraoperative team. You have the surgical team. So in this phase, it begins when the patient is received from the surgical area, and it lasts until the patient is transferred to recovery. Although the surgeon has the most important role, there are other key members. Okay, so the surgeon, he's the leader of the team. They're responsible for performing the surgery effectively and safely, but that surgeon is dependent upon other members of the team, for that patient's emotional well-being and for physiological monitoring. The anesthesiologist or the anesthetist, they're important because they provide a smooth induction of the patient's anesthesia in order to prevent pain. They're responsible for relaxation of the patient. They monitor the physiologic status of the patient during the procedure, and this could include the patient's oxygen exchange, their systemic circulation, neurological status, vital signs. And then he informs or advises the surgeon of any impending complications. Okay? You have the scrub nurse or the assistant. That's a nurse or a surgical tech who prepares the surgical setup. They maintain surgical asepsis while draping and handling instruments. They assist the surgeon by passing the instruments, the sutures, the supplies. That scrub nurse assists the surgeon throughout the whole process, the whole procedure, and they anticipate the required instruments and set up the sterile table. They check the equipment, the materials, needles, sponges, any instruments that would be also needed to close the incision. And they make sure that all of the instruments are accounted for to make sure that nothing is left in the body. And that has happened. They had a count and sponges have been left in patients and things of that nature. So the scrub nurse's job is very, very important. You have the circulating nurse. They respond to the requests of the surgeon. The anesthesiologist, they get supplies, they deliver supplies to the sterile field, and the circulating nurse carries out the nursing plan of care. Okay? The circulating nurse also manages the operating room and protects the safety and any health needs of the patient, the monitoring of activities of the members of that surgical team, and they check the conditions of the operating room. Okay. Talking about the surgeon, anesthesia, the scrub nurse, and other important members of the surgical team. So now we're going to move into the preoperative period. Okay. So during the preoperative phase, the patient is prepared for surgery. The patient may arrive and be admitted to the hospital or ambulatory care unit before the surgery is scheduled. In this phase, the preoperative nurse and the anesthesia professional will assess the patient. They'll start an IV if one hadn't already been established. They obtain the lab work. They review the procedure. They make sure they review the labs, prior to the procedure, and they make sure that any preoperative medications are administered if ordered. During the preoperative phase, the surgical consent is signed. The anesthesia consent are signed. The anesthesia professional, they need to meet the patient, review the medical history, explain the anesthesia process to the patient before the surgery starts. The surgeon signs the surgical consent for the procedure. The surgeon marks the operative site on the patient's body. The RN circulator, they meet with the patient. They receive report from the preoperative nurse about the patient. The RN circulator confirms that the consents for surgery and anesthesia are signed. The RN circulator makes sure that she checks the patient identity, confirms confirms the procedure. Confirms the procedure with the patient and answers any questions for the patient and family member. So when all of the preoperative procedures and requirements are complete, the patient is transferred to the emergency room, often by the RN circulator. Okay, so here we are, preoperative. We need to get a history. We need to assess the patient's level of functioning, their daily activities. So we need to know this ahead of time so we can assist in the patient's care, the plan of care and recovery, or if they're going to have to go any kind of rehabilitation. Okay. During this time, you check the pre-op orders, you check the history, you check the electronic record. You want to make sure that the patient doesn't have any internal or external prosthesis. So as a preoperative nurse, you're checking for the mouth for dental caries, dentures, if they have any partial plates. You want to make sure they don't have any decayed teeth or dental prosthesis that may become dislodged during the intubation for anesthesia and possibly occlude the airway. Okay, so during this time and getting the assessment, you want to see if they have any sensory impairments, any language barriers. You want to ask about any cultural differences or religious and spiritual beliefs. You want to kind of see if there's any potential of infection. So antibiotics can be given immediately before the first surgical incision to prevent any infection in those that are in increased risk. So those would be people with valvular heart disease, to prevent endocarditis, to prevent any contamination of the wounds. The preoperative nurse also assess for pain and discomfort, and that's an ongoing assessment. Okay, especially in the presence of trauma, you want to see, okay, how's their pain? How's their pain? But understand, when you use opioids, it can cause constipation. So you want to teach the patient about stool softeners to assist with elimination. You want to also note, when you're obtaining all of this history, drug and alcohol use. You want to see if the person is acutely intoxicated. Is the person going to be susceptible of any injury? You also want to see any presence of prosthesis, corrective devices, and then note their personal belongings and where they're located. Okay. Also in the history and the assessment, you want to look at medications. You want to ask them specifically about prescribed and over-the-counter medications. So you obtain the allergies from the patient's history. Now those with latex allergies, you want to make sure that they're placed in a special designated room. And then you want to ask again about food, drug allergies. Okay, now the reason why it's important to ask and note medication therapy, previous medication therapy, or the medications that they were taking prior to needing this surgery, it's essential, because whatever medications that the patient was taking can affect the surgery. So that's why the nurse and the anesthesiologist really ask about medications. Okay, so I'm going to go over some medications that can cause certain concerns during the upcoming surgery. Alrighty, so you have 1, adrenal corticosteroids. These are not to be discontinued abruptly before the surgery, because once discontinued, there could be cardiovascular collapse may result from those taking steroids. And a bolus of steroid is administered IV immediately before and after the surgery. Okay, because during times of stress, corticosteroids are essential for life. Corticosteroids help the body kind of maintain itself during stress. So, if a person had been taking those, you don't want to stop those. Okay? Do not stop the corticosteroids. You want to make sure if the patient was on any kind of diuretic, because a thiazide diuretic can cause excessive respiratory depression during the anesthesia administration. You want to make sure that the patient isn't on any phenothiazines, so like antipsychotics like compazine or thorazine, because these medicines may increase hypotensive actions of the anesthetics. You want to see if they're on antidepressants, because those MAO inhibitors can increase the hypotensive effects of anesthetics. You want to see if they're on tranquilizers. Medications like barbiturates, diazepam can cause increased anxiety, tension, and even seizures if withdrawn suddenly. You want to know if the patient is on any insulin, because when a patient is going into surgery, there's interactions between the anesthetics and the insulin. They have to consider those. Then you want to know if they were on any kind of antibiotics, because mycins, drugs like neomycin or streptomycin, can cause problems when combined with certain muscle relaxants. So if you do the certain antibiotics with the muscle relaxants, it'll result in the nerve transmission being interrupted, and then a person may become apneic due to respiratory paralysis. So that's why it is so important to know the patient's medicine. That's why it's so important to find out what they're taking, so it can be in the medical record, it can be in the EHR. Okay? You also want to know about herbal supplements. That's something that we typically don't ask about. Those can interfere with the anesthetic agents. So you got to know about those. And then also you want to see if the patient's on any aspirin. That may not be on their profile, but maybe the patient said, well, my dad took aspirin or somebody else takes aspirin, so I'm going to take some aspirin too. But they may have not disclosed it. So you want to make sure, are they on aspirin? Because that may affect post-op bleeding. Okay? So now we're on to the physical assessment. You've done all of this history. So now you're on to the physical assessment. Okay? So the data that you obtain depends on the severity of the problem and the involvement of other body systems. Okay? So every surgery is going to be different, and depending on the surgery, it may affect different things. But we're just going to kind of go through all of the systems. Okay? So number one, the cardiovascular system. The cardiovascular disease, the patient have cardiovascular disease, it can increase the risk of complications. Okay? So surgery may have to be deferred until the patient has any kind of medical treatment that can improve their condition. So, if the patient says they have a history of cardiac problems, heart failure, pulmonary edema, peripheral vascular disease, any kind of vascular stasis, because that's going to increase the risk of thrombus, clots, okay? So when you're assessing them, they may have changes in their heart rate. When you're doing your assessment, you want to try to avoid any sudden changes, any prolonged immobilization, hypotension, hypoxia, overloading the whole circulatory system with too many fluids of blood. So you need to know these conditions because that's going to determine the care of the patient. Okay, you have a patient in heart failure, pulmonary edema, you sure don't want to load them up on a lot of fluids during surgery. Okay, so you need to know these things. The respiratory system. You need to know if the patient has any history of pre-existing pulmonary problems. You can get blood gases, assess their pulmonary function, especially during your assessment, because surgery is usually contraindicated for a person who has any kind of respiratory infection. So you need to know if they have any recent infections, any coughing, do they smoke? Look at their respiratory rate. And if this surgery is scheduled, see if they can stop smoking months before surgery. Or at least, can you not take a cigarette 24 hours before surgery, okay? During this preoperative phase, you want to teach them breathing exercises, how to use an incentive spirometer. That's very important, the incentive spirometer. You want to make sure that, do they have any underlying respiratory diseases, asthma, chronic obstructive pulmonary disease, COPD, okay? Because these can affect recovery. You want to look at their hepatic, their renal, urinary system, okay? So surgery is contraindicated in patients with acute nephritis, renal insufficiency, or any other kind of renal problems. You want to make sure that they don't have any disorders of the liver, because that's going to affect how the anesthesia is metabolized. Okay? So if a patient has a disorder of their liver, you want to make sure that when you're looking at the lab work, that the liver function tests, make sure that they're normal. And then you want to see their acid-base balance. And y'all have learned that in Ms. Smart's lecture. Look at their musculoskeletal system. How are they moving? What's their range of motion prior to surgery? You want to discuss DVT prophylaxis. So use of the sequential compression devices, maybe the antithrombolytic hose, either knee high or thigh high, okay? But when you tell them, and, as a nurse, when you're putting them on, you want to make sure that you're constantly looking at that skin, okay? You want to see if the patient can get up as tolerated. And then, that'll be part of the teaching. Once you're able to get up, we'll be able to take off these sequential compression devices, okay? And you want to also explain them about frequent changes in position after surgery. Encourage them to get up and to move, because this will improve circulation, it'll prevent venous stasis, and it will promote optimal respiratory function. You want to show them how to turn from side to side, okay, without causing pain. You want to, without, making sure that, you want to make sure that they know where these IV lines are, the drainage tubes, any other kind of apparatus. So while they're changing position, they don't dislodge anything. I mean, if some of you have worked on a trauma floor, you would have seen that patient, major surgery, maybe they have external fixators. They don't want to move, but you see how important moving is into helping with their recovery. The pre-op nurse is going to discuss any special position that the patient needs to be in. Exercising of their extremities. Use of their upper body mechanics. Okay, all of this is important. Immunologic function. We talked about allergies, any sensitivities, immunosuppression. Okay, endocrine function, the diabetes. Are you taking any corticosteroids? any insulin. Okay? You're going to have to remember to monitor their blood glucose levels before, during, and after surgery. You want to make sure that you report any steroid medication for any purpose. Okay? You want to let them know that they've had any steroids in that previous year. Let the anesthesiologist know and let the surgeon know. You want to check their nutrition status. Okay? You need to know their height, their weight, so that'll tell you, are they obese or are they not obese, are they thin, or are they, of adequate size. You want to check their protein levels, nitrogen balance, because understand, obesity greatly increases the risk and severity of complications during surgery. Okay? You want to check their fluid and electrolyte imbalances. Are they dehydrated? Any hypovolemia? Any electrolyte imbalances? Instruct them about food and water needed to be withheld 8 to 10 hours before surgery. That's common. Things change all the time. You may see something different. It all depends on the institution that you work with. But let's just say 8 to 10 hours. Usually they say NPO after midnight, nothing by mouth after midnight. It just all depends on the institution and what the patient's getting, what procedures being done. But you also want to monitor the patient with chronic alcoholism for malnutrition. Some of you may have seen, people come in and they have fallen out of a tree, or they fell down a flight of stairs or a ladder, but then you realize alcohol is on board. So you want to make sure that, there aren't any nutritional deficits because of that. And a lot of you may have seen, and this is just information, patients on the multivitamin. They're on thiamine, things of folic acid, so things of that nature. Okay? And then also the biggest thing about alcohol withdrawal is the delirium tremens, or alcohol withdrawal, that can occur up to 72 hours after alcohol withdrawal. Okay, so you really want to make sure that you assess for that. And, lastly, let's talk about psychosocial. You have a patient, you want to reduce their fear. You want to reduce their anxiety. You want to give them support. You want to be a good listener. You want to be empathetic. You want to acknowledge their concerns and their worries. You want to teach them strategies that may be useful for relieving tension and anxiety. Okay? Patient's going to say, I'm scared. Acknowledge that they're scared. Acknowledge it. Let them know that you hear them, that you're listening to them, and that you're going to help relieve or help the best way that you can some of those fears, either with education or being by their side. Okay? Let's move on to labs. We've said a lot. Let's move on to labs. There's a lot in periop. Okay? There's a diagnostic table. I think it's page 1350 in your book. Kind of goes over a lot of these. But let's talk about it. A lot of these are the common pre-op labs that you see. CBC, that's important, especially deviations. Okay, it needs to be corrected prior to surgery to make sure, to keep the patient safe. Safe before surgery, and especially before giving any anesthetic agents. So CBC is important. You're looking at the white blood cell count. It's indicative of any inflammatory process. Okay? But if a person comes in with appendicitis, you're going to expect the white count to be elevated. Okay? But sometimes surgeries can be postponed because the white blood cell count is too elevated. Okay? So peritonitis, cholecystitis, they may give antibiotics prior to. It just all depends. Some of those things are corrected with surgery, so it just depends. But you want to make note of the WBCs. You also want to see if their white count is too low. meaning there's some kind of viral process going on. You know, their immune system may be dysfunctional. You want to look at the hemoglobin and hematocrit. The hemoglobin looks at, okay, has this person lost blood or are they anemic? So this is going to impair tissue oxygenation. Alrighty. And this may also impair that binding of the inhalation anesthetics. So they may have to titrate how much anesthetic they're going to have to give the patient because of a reduced hemoglobin. The hematocrit may indicate dehydration, and if it's decreased, maybe the patient's fluid overloaded. So that's why it's so important to know your labs. And that's why when we ask you on your care plans, interpret these labs for us related to your patient. This is why that's important. You want to look at the electrolytes. Okay, a decreased potassium can affect cardiac muscle contractility. It can decrease cardiac output. So an elevated or decreased potassium can cause cardiac dysrhythmias. So these need to be corrected prior to surgery. Okay, a decreased potassium also can adversely affect the patient's tolerance to anesthesia. Here we go, anesthesia again. You need the potassium. So you may be working on a unit and you see multiple K riders, okay, prior to surgery. You want to look at their ABGs, assessing their respiratory status. You need to know if they're a smoker, like we talked about before. Coagulation times. That'll interfere with intraoperative or postoperative hemostasis. You know, hypercoagulation can increase thrombus formation, especially if the patient's dehydrated and the patient has decreased motility. So that's why it's important. Education's important. Knowing your labs are important. Urinalysis. You want a urinalysis to make sure that they don't have any white blood cell counts or bacteria indicating infection. Okay. Then also with a urinalysis, if the specific gravity is elevated, that may say they're dehydrated. Okay. Pregnancy test. Alrighty. Female patients, pregnancy test. Positive findings may affect the procedure, but emergencies, pregnancy test does not, a positive pregnancy test does not stop surgery. Okay. Chest x-ray. You want a chest x-ray. Make sure that the patient is free from any infiltrates. They don't have pneumonia. Looking for any masses. Do they have COPD? EKG. Okay. If it's abnormal, they need to fix it prior to giving anesthetics. EKG going to show them any kind of heart abnormalities. Murmurs need to be cleared by cardiology before surgery. So anybody over 45 will get an EKG automatically. Albumin, there goes with that malnutrition. Albumin, adequate healing. We need to make sure that albumin is normal. Blood glucose. Normal levels help healing and perfusion. It will increase under stress, secondary to cortisol levels because of surgery. So you may see a sliding scale in the chart as a precaution. Okay, and I think with the perfusion lecture, I think Ms. Troxclair had talked about fight or flight, and she talked about, you know, cortisol and all of these hormones, and with the fight or flight, and you know, just we were talking about heart failure, but it still all goes together. Cortisol levels go up, blood glucose levels go up. So the need for insulin, there may be a need for insulin. Let's see. So we talked about the lab data, medical history, health, surgical risk, perioperative safety. Okay, so very important. The nurse's responsibility, safety, highest priority. You want to make sure, like I said, identify the patient, the procedure, the surgical site. We talked about that. We want to make sure in surgery. So now we've kind of moved in surgery. You want to make sure that if you're in there, that the patient is strapped at the knee, the arms are at 90 degrees. You want to make sure that the cautery pad is applied and in place. You know, the cautery pad is used to stop any bleeding. You want to make sure that their feet are placed correctly because you don't want any dislocation of the hip. Safety, you know, you want to make sure that the equipment is individualized for the patient. We talked about physical alignment, grounding devices. So we talked about the cautery to stop the bleeding. You want to make sure that that's grounded because if not, it can burn the patient. We talked about the sponges and the needles, making sure that they're all counted for, and that all of the documentation. So all of this has to do with safety. You know, safety, like we said, is the number one priority for the patient. Okay? So things that we need to do to, you know, promote safety. We talked about NPO status. We talked about removing things. So you want to remove contact lenses, glasses, jewelry, okay? Because jewelry left on the patient causes burns, swelling, infection. We'll make sure the bras are removed. Piercings, you know, dentures, implants, you know. So you want to make sure all of these are removed because these things can cause death or permanent disability if they're left on the patient. If you didn't go through and do your assessment and remove all these things, this could, you know, something can get lodged in the throat, or, you know, like we talked about dentures. You're putting they're intubating the patient, and boom, it occludes the airway. So that's why all of this is important. Safety is so important. The timeout. Like we said, verify the patient identity, procedure, surgical site, is the timeout is the process to prevent wrong site surgery. You want to make sure everybody knows timeout. This is the right patient. This is the right procedure. This is the right site. Okay? That's very important. So let's talk about legal preparation. Informed consent, you know, is written in layman's terms and medical jargon. The nurse reinforces. It's not the duty of the nurse to get the informed consent. It's not the duty of the nurse to explain the procedure. They're supposed to just make sure, hey, is this your signature? But, you know, you can ask the patient, hey, did you understand what the surgeon said? You may ask them a few questions to see if they understood. And if they didn't, you need to call that surgeon back, because we talked about that in advocacy. You know, you need informed consent for any invasive surgery, you know, sedation, and even non-surgical procedures that can impose a risk to the patient. You want to make sure that a family member is there to give consent if the patient is a minor, or the patient's unconscious, or the patient is incompetent. And an emancipated minor, they're married or they're independently living on their own, can sign their own surgical consent. Okay, that would be the only difference. And we talked about this in advocacy. Can a family member use interpreters for consent? Or can you use, family members as interpreters for consent? No. It has to be done by a medical staff or a trained medical professional. We talked about that in advocacy. Can a 16-year-old give consent for their 1-year-old child? Surely can. But if the 16-year-old needs consent, the parent has to sign. but the 16-year-old can give consent to their own child. Okay? True emergency overrides consent. Informed consent is necessary to be signed by the patient before the surgery. Okay? Because it protects the patient against any unsanctioned surgery. It protects the surgeon. It protects the hospital against any legal action. It ensures that the patient understands what's about to happen. It shows that the client's decision for surgery was their own decision. They didn't force them or cause any pressure. And as a side note, it always lists death as a possible complication of surgery. Okay? Let's see. Oh, you need a blood surgery, a blood transfusion consent, the advanced directives we talked about, an advocacy, power of attorney, all of these need to be signed and placed into the patient's chart. Now teaching. There's a lot of stuff that you teach in surgery or in the perioperative teaching. So before, surgery. And we talked about a lot of these, okay? We talked about making sure that they understand the procedure. We talked about making sure that they, have, they're prepared. So if you have to give them reading materials, if you have to show them videos, do it. Make them understand. Let them know that they're going to have a ventilator. They may have tubes and other types of equipment when they get out of surgery. Okay, let them know that family will be able to visit after surgery, and the spiritual advisor can come. Okay, we want to talk about. We want to inform them about medications. They're going to get pain medications, okay? Because pain relief will help them cough and deep breathe better. They're going to, because pain is a big thing. So, you need to let them know we're going to manage your pain. You have to let us know, how you're feeling and what your pain scale is. But, reassure them that, you're going to have the surgery and yes, you're going to have pain. But, us controlling your pain is very important. You also want to let them know about, antibiotics that they may be receiving prior to or after the surgery. You want to make sure that you let them know about, we talked about anything that's expected during the surgery, any specific procedures that's going to be performed, but your focus all centers around safety. Okay. And that's why I was saying that a lot of this is a combination of everything that y'all have been learning in each one of your concepts. It kind of all comes together with in periop and in this lecture. So we talked about the checklist, the site, emptying the bladder. Before surgery, make sure they go to the toilet or the bedside commode. We talked to, let them know about sedation, alleviating pain. We're going to make sure that your pain's controlled. We're going to make sure that you don't have any nausea or the vomiting. We're going to give you medications that can help with secretions, kind of prepare them for all of this. This is a surgical consent, not a surgical, I'm sorry. This is a pre-op form, so you can see, okay, were the pre-op orders written? Do they have the ID band on, the allergy band? Do they have a gown? Are they MPO? So it kind of, you check off, yes, this was done. Yes, this was done. That was done. So this is just a form that they use in surgery. Here are some other things, you talk about pre-op medication, eye drops. We talked about medical history, skin prep. Some places, they have where you use mupropion or Bactroban to help prevent MRSA. These are some medications that are used in surgery. And, surgery, there are lots of reasons for surgery. It can be a diagnostic, reconstructive, palliative, or transplant. Sometimes like they're curative, so an appendectomy or a thyroidectomy. Constructive, cleft palate repair. Exploratory, something's going on, so they want to do a exploratory lap. Person's having abdominal pain, they may have a cosmetic surgery. Okay, sometimes surgeries are required, emergency, urgent, elective. That may be some of your cosmetic surgeries, a facelift or something. Let's see. So documentation, hands off. That's important. You want to make sure that there's a handoff or an S-bar, the communication between the nurse that's taking the patient from the pre-op to the intraoperative environment. Okay, they need to know what's the patient's condition, their baseline, vital signs, things of that nature. All righty. And then now they're in the intraoperative period. All righty. A lot of the work is performed by the RN circulator and the scrub person. Well, again, all of this is done way before they even get into the OR. All righty. So the OR is prepared. The nurse ensures that, the patient's in the proper OR bed. That's important. That, the equipment's there, the instruments are there. And then after the patient is in the OR, the RN circulator assists the anesthesia professional with anesthesia, the induction of anesthesia. And this should be a quiet time. After the induction, the patient's positioned for the surgical procedure by the surgeon, the assistants, and the RN circulator. After the patient is properly positioned, the RN circulator preps the patient, initiates the timeout before the surgery begins. The timeout is critical, like we said before. It's a critical safety procedure that involves the entire surgical team in verifying the scheduled procedure, the right patient, the right site, and that all the necessary equipment is ready to go. Okay. Intraoperative sepsis. In the operating room, everybody shares their responsibility. The center of that sterile field is the incision. So the area that's being operated on has to be prepped to remove any kind of microorganisms. Okay. You shouldn't have any, like we talked about, no piercings, no nail polish, no rings. All that has to be removed. Okay. Like we said, the surgical field, that's the incision is the center. Aseptic technique, scrubbing, gowning, gloving, set up the room. The sterile parts of the gown is the front of the chest at the table level. And sleeves 2 inches above the elbow. Because all of that has to be sterile during this process. Alrighty. In the intraoperative environment, this is just some information. You have unrestricted areas, the holding area. Family are allowed in there. The semi-restricted, you see they have to wear scrubs, shoe hair, and face covers. The restricted area is the operating room. You know, the attire above, hair, shoe, facial covers, plus they're in sterile robes, gowns. They're gloved up. Everybody wears a mask. And then the perioperative area has a higher airflow exchange to kind of help trying to prevent infection. Okay. Intraoperative safety. Here's safety again. You want to do a chart review. Look at all of your tests, your labs. Make sure the history and physical is signed. Is the patient ID on? Surgical site marked. Pre-op checklists completed. All pre-op orders are completed. We talked about alignment. You want to protect the skin and bony prominences. We talked about electrical grounding. If the cautery equipment isn't grounded, patient can burn. You want to make sure their monitoring leads are on, the warming blankets are there, and we talked about the scrub nurse. Correct count of the surgical equipment and the sponges, very important. Okay. They have anesthesia. These are some comments about the anesthesia that they can use: the general, local, regional, spinal, epidural. Okay. And then we have a YouTube video kind of talk about intraoperative anesthesia. Alrighty. Risk, very important. Anaphylaxis, life-threatening, severe allergic reaction. Got to make sure you're on your toes to notice subtle change in the patient. That's why it's so important to know your baseline of your patient. Alrighty, to see if the slightest thing changes. Malignant hypothermia, very important. It's rare, but potentially fatal. It's an inherited disorder. That's why getting that family history is important. That results when the patient is exposed to certain anesthetic gases and muscle relaxants. The muscle relaxants, acetylcholine. Okay. The patient may have tachycardia. A rise in carbon dioxide, cardiac arrhythmia, muscle rigidity, rise in temperature. The treatment is discontinuing the anesthesia agents and administering dantrolene, which is a skeletal muscle relaxant. So the patient is going to be acidotic, elevated heart rate, decreased O2 sats, and have anoxia, which is the loss of oxygen to the brain. Okay, this is serious. Alrighty. And I have some information explaining, the complications that can occur during surgery. These are some other things that you talk about with the complications. Elderly. You want to monitor them all the time. You want to monitor for dehydration, risk for pressure ulcers, development of thrombosis, sensory defects, and what should we do to reduce those risks? Proper body alignment, prevention of obstruction of circulation, respiration, nerve conduction. When a patient has a complication, any patient, doesn't have to be an elderly patient, but any patient, you want to make sure that their airway is open. You want to make sure that we always have oxygen. We want to notify the surgeon if there are any kind of complications. And intraoperatively, the surgeon is there. But in any aspect of the perioperative environment, if there's anything that's concerning, please let your surgeon know. Alrighty. And then also, if a patient you notice has a toxic reaction to anything, if it's left untreated, unconsciousness, hypotension, apnea, cardiac arrest, and death may result. So that's why it's very important to stay on top of your patient and what's going on with your patient. So let's move on to the postoperative period. Handoff. We talk about points to consider. Handoff, important. the handoff of a patient from the RN circulator to the PACU nurse is super important. Alrighty. The RN circulator gives a full report to that receiving nurse, including the procedure performed, the medications given during the procedure, any allergies, blood loss, or any vital information about the patient. Okay, the patient, as you should be aware, is connected to monitors such as an electrocardiogram. They have a pulse ox. That post-operative nurse monitors the patient closely, administers pain medicines, give nausea medicines if needed, and they stay with the patient until the anesthesia wears off. And then that patient is then prepared to go to the medical surgical floor, another unit, or go home. Okay. So understand the post-operative period begins when the patient is transferred from the operating room to the post-anesthesia unit or PACU. Okay, and it ends when the patient has fully recovered. So there are a lot of things that we have to try to consider in the post-op period. We talked about the handoff of report. We talked about the things that they're going to talk about, just general information, the history and things of that nature. They're going to also talk about any unexpected things that happened, okay? And they may say, okay, well, this is the first thing that you have to consider or look at or do now that the patient's in the post-anesthesia unit, okay? So during this time, this is where the patient, like we say, is recovering. We're giving them pain medicine. We're trying to, monitor them restoring their body homeostasis. We talked about alleviating pain or nausea, preventing any kind of post-op complications. And then in the post-op period, this is where we start putting things together to allow the patient to be discharged home. And then we also teach as well. So in the post-op period, we talk about safety again. This is just some information on safety, having the patient lie on the side. But the biggest things are, you want to prevent or relieve any complications. You want to have the patient have optimal respiratory function. You want to support their psychosocial well-being. Tissue perfusion, cardiovascular status maintenance, observing the maintaining of adequate fluid intake, nutrition. You want to make sure they eliminate. So before they go home, they're going to have to be able to go to the restroom. You want to be able to give them adequate food and electrolyte balance. Make sure their renal function is maintained. Encourage activity, mobility. Make sure they're having adequate wound healing, infection control. Try to find ways of really helping them relieve their anxiety. Promote safety, okay? You really have to, in your post-op assessment, you really want to talk about, looking at the incision site. We talked about vascular status, okay? Every time the patient is moved, the nurse has to consider the location of the surgical incision. You don't want to put any strains on that surgical incision. The patient comes out the operating room, they're going to have tubes like we talked about. So position should be adjusted in order to prevent any obstruction of the drains. All right. When you do your assessment, because a lot of post-op complications can occur. That's why assessment is so important. You really have to be able to assess the patient and notice if they're having any changes. The most important thing is assessing, for adequate air exchange and noting of the patient's skin color. You want to make sure that the access to the airway is patent. Respiratory assessment is the most critical assessment to perform after surgery. I mean, it's the most important thing of anyone receiving any kind of general anesthesia. The patient remains at risk for pneumonia, shock, cardiac arrest, respiratory arrest. We talked about these. Venous thromboembolism, GI bleeding. So if you're watching a patient and their O2 sat drops below 95, or the patient's pre-surgery baseline. So if the patient just say was 98% and now after surgery they're dropping, they're 95, 94. Okay, you need to let that surgeon or the anesthesia provider know. If it drops more than 10 percentage points, you're going to have to call a rapid response team because something's detrimental is going on. In the post-op period, we talked about verifying their activity. You need to know their level of consciousness. Sometimes a patient, when they come out, they may be over-sedated. So that's why that assessing that respiratory status and making sure that airway is open is important. And, if we find that the patient just keeps, once you awake them, they go right back into deep sedation again, give Narcan. And if the person is not responding to that Narcan, there you go, you're calling the rapid response team again. Post-op, you want to, make sure you assess their cardiovascular status, vital signs every 15 minutes, report any blood pressure changes, abnormal heart sounds, fluid volume deficit, they start hemorrhaging. You want to definitely look at bradycardia. So that's why your vital signs are so important. Okay. And then the operative site, where the incision is. The dressings should constantly be checked, but should never be removed. That surgeon is supposed to remove or change that first dressing. Okay. So I kind of talked over this slide a little bit, but what would be possible? What would possible post-op, complications, what would occur, and how would we fix those complications? So let's just kind of run through them. I think this is we talked about this, and that's one thing, like I said about periop, it's the same thing. You're dealing with all your concepts, your perfusion, your oxygenation, your mobility. I mean, all of this is just kind of all of periop. So, your airway, you want to keep it in place until the patient is fully awake and tries to eject it. The airway is allowed to remain in place until while the patient is unconscious, to keep it open and prevent the tongue from falling back. When the tongue falls back, the airway passage is obstructed. Okay. You want to make sure that they're turning, cough, and deep breathing. One thing that you want to stress more than anything post-op is using that incentive spirometer 10 times an hour, because you want to prevent pneumonia. You want to make sure that they're getting adequate oxygenation, because you don't want any alteration of their cerebral function. That's why, noting that post-ox and seeing what's going on. You want to turn the patient every 1 to 2 hours. Okay, on that unaffected side. These are all, things that can happen. One thing I want to throw in there, after surgery, especially abdominal surgery, you may give somebody a pillow to splint with coughing, because, you want to kind of decrease the pressure from a cough, because, you can cause, that coughing and that deep coughing after surgery can cause incisional complications. The sutures will come apart. Okay, and we'll talk about that in the next couple of slides. Circulation, you want to make sure that you recognize symptoms of shock, hemorrhage, cold extremities, a decreased urine output, less than 30 cc's an hour, a slow capillary refill, greater than 3 seconds, dropping of blood pressure, tachycardia, increased heart rate. These are all the complications. Thermal regulation. You want to monitor for hypothermia or hyperthermia. You want to monitor the patient for post-anesthesia shivering. This is a hypothermic state. It happens in patients 30 to 45 minutes after they're in PACU. So you want to make sure that the patient regains their thermal balance. Okay? Fluid volume. You want to make sure that they don't have any fluid and electrolytes imbalances. Nausea, vomiting. If a person's hypovolemic, they'll have a decreased blood pressure, decreased urine output, increased pulse rate. You'll have increased respiratory rate. With hypervolemia, you'll have increased blood pressure. Changes in lung sounds. You'll have crackles. All right? If there's something wrong with the GI, complication, we talked about nausea and vomiting. We talked about the stress to the incision site. You want to turn the patient to the side to prevent any kind of risk of aspiration. Okay? Another complication could be a paralytic ileus, intestinal obstruction. So you have to monitor all these things. You want to monitor their skin. You want to look at that wound. You want to look at the wound type, the wound drainage. You want to inspect the dressings, reinforce them if necessary, especially if significant blood loss is noted. So if significant blood loss is noted, you reinforce and you have somebody call that surgeon. Okay? So these are all of, these are the things that you have to try to anticipate that can happen after surgery. Okay? Also think of, and before we move on to wound healing, also think of dizziness, orthostatic hypertension. Okay? And we talked about pneumonia and DVT and those other complications. Okay? So that's where all of this kind of comes together. That's why I keep trying to say this. Peri-op is just all of the concepts all together. Everything that you learn, it just encompasses everything. So let's move on to wound healing. And we're almost close to the end. Wound healing, okay, so you want to assess normal wound here, impaired wound healing. Infective wound healing can be seen most often between the 5th and the 10th day of surgery. Okay. For the normal wound healing, the edges are well approximated. There's no redness, there's no drainage, no edema. If it's impaired, you'll see, like I said, between 5 and 10 days. It can be caused by infection, distension from edema, and a paralytic ileus, stress at the surgical site. Impaired wound healing can be due to obesity. It can be because of diabetes. Okay, so if you have an infective wound healing, like I said, diabetes, obese people, malnourished people, people with immune deficiencies, and those using steroids will have impaired wound healing. So there's two things that can happen. You can have a dehiscence, a partial or complete separation of the outer wound layer, sometimes described as a splitting open of the wound. If dehiscence occurs, you want to place a sterile dressing soaked with normal saline to the area to keep it moist until the surgeon comes. Evisceration is where there's a total separation of the wound layers and a protrusion of the internal organ comes through the wound. Okay? Now, if a dehiscence or evisceration occurs, you want to stay with that patient. Have that patient stay quiet. You don't want them anxious. You don't want them nervous. Okay, you want to keep them calm. Have somebody contact that surgeon and prepare that patient for that wound to be closed. Try and instruct them to not cough, and then document all of your findings of everything that you're doing, all the actions and stuff. Okay. If they also, okay, let's talk about this. If they also experience significant bleeding post-op, you want to apply pressure if you can, if it's applicable, and reinforce the dressing. Okay, and a dehiscence or an evisceration can occur, coughing. We talked about coughing, we talked about splinting, vomiting, straining. Okay, so these can occur, and when they occur, especially evisceration, you need to call the surgeon. Let them know, hey, this is what's going on with the patient. All righty. Drains. I have a little video on here about JB drains. JB drains are Jackson Pratt drains. This device collects fluids from inside the surgical site. The bulb is compressed to establish a vacuum. Okay, so you want to make sure that that bulb is compressed. Okay, to create that vacuum, because if it's not compressed, that bulb is not going to work. Okay, so look at that video. A hemovac drain, so that's a JP drain. That's how you empty it. You pop the top. You pop that stopper open, and then you measure the fluid, and then you create that vacuum. You put the stopper back in, and then that will allow for, if there's any drainage, it can collect with that vacuum inside of the drain. A hemovac drain. Do I have that? Oops, no, I don't. A hemovac drain is a draining device. It's like a Jackson Pratt. It has a larger capacity to collect fluids. It can collect more fluids, but it's like the Jackson Pratt. Okay, it creates a suction that can pull drainage out of the wound. And a Penrose drain, this is used to facilitate, kind of keep a wound open. Okay, a pin is usually placed in there to prevent that that covering from advancing into the wound. Alrighty. That kind of sums up the Periop lecture. It really kind of, like I said, it encompasses all of the other concepts. If you have an idea of the other concepts, you can really put it all together with Periop. It kind of builds. Periop is just, like I said, it's all inclusive of all of the concepts that y'all have learned. So this is a lot of material. Study hard, watch the videos, and do your best.